Welcome to the Radonc Smart Review GI Cancer series. Today, we're really diving deep into a critical area of GI oncology, rectal cancer.
Yeah, absolutely. It's a fascinating topic.
It really is. And we want this to be more than just facts. It's about building a solid foundation, something essential for radiation oncology residents, really at all levels, to truly grasp and navigate this disease in practice.
That's exactly right. Rectal cancer is, I think, maybe the perfect example of how truly multidisciplinary evidence-based care
Mm.
has just completely transformed patient outcomes.
Right.
The whole story of how treatment evolved here, it's kind of a masterclass, isn't it? In how surgery, radiation, chemo, how they all fit together. The sequence, the precision,
Mm.
it's made a huge difference for patients.
Mm.
So we're going to lay down that essential groundwork today. We'll cover the fundamentals, the anatomy, which is crucial, and then that surgical innovation, TME. That honestly changed everything.
So think of this as your comprehensive tutoring session. We'll walk through the essential workup you need to know, dig into the critical anatomy, those landmarks that tell us where the tumor might go, how we shape our radiation fields. We'll dissect modern MRI staging, which is just vital for planning treatment today. And then, like you said, explore that game changer, total mesorectal excision.
TME.
It's all about mastering these core ideas, seeing how they connect, and really getting why treatment evolved this way, why we do what we do for our patients.
Exactly. And, understanding these fundamentals, it's not just academic. It really dictates every single clinical decision we make.
Right.
When you get these core principles, the whole treatment plan for rectal cancer, it starts to make, intuitive sense.
Okay, so let's ground this in a real-world scenario, something you'll definitely see. Imagine a, say, 58-year-old man, pretty healthy otherwise, presents to his primary care doc with rectal bleeding. It's been going on for a bit.
Classic presentation.
That symptom, rectal bleeding, it's not something you just brush off, right? It's a red flag. It has to trigger a full workup. Lots of things cause it, but rectal cancer has got to be high on the list. You just can't miss it.
No, you absolutely can't. So the initial evaluation for a patient like this, it always starts with a really thorough history and physical.
Okay.
You get the symptoms, past history, family history, all that. But a really crucial part, one that sometimes, maybe gets a bit rushed.
The DRE.
Exactly. The digital rectal exam, or DRE.
Yeah, the DRE. Sometimes it feels like just a quick check, maybe uncomfortable, but it sounds like it gives us a ton of immediate, really useful info for rectal cancer. What specifically are we looking for? Why is it so key?
You hit it right there. It is so far from just a formality. For rectal cancer, it's incredibly informative. You get immediate, tactile feedback.
Okay.
First, and maybe most important, the DRE helps us figure out the tumor's distance from the anal verge.
Right, how far up it is.
Exactly. And that's critical because it directly impacts whether the patient might be a candidate for sphincter-sparing surgery. Can we avoid a permanent bag?
Huge quality of life issue.
Massive.
Mm.
So based on that distance, we start categorizing. Is it low, like less than 5 centimeters from the verge? Is it mid, maybe 5 to 10 centimeters? Or is it high, 10 to 15 centimeters up?
And that location matters because
Because it profoundly influences lymphatic drainage patterns that tells us where to aim our radiation,
right.
the chance of the sphincter being involved, and the type of surgery needed. Low anterior resection versus, an APR, an abdominoperineal resection.
So that distance measurement really sets the stage early on. What else can you feel on the DRE?
Well, beyond just the distance, we're carefully feeling for the tumor size, roughly how much of the circumference it takes up, and critically, how fixed it is.
The fixed meaning stuck.
Yeah, is it mobile? Can you move it around? Or is it partially stuck? Or is it completely fixed, like stuck to the bone or other structures?
And if it's fixed?
A fixed tumor suggests duper invasion. It might be growing into nearby organs, maybe the pelvic sidewall. That pushes it towards a T3 or even a T4 stage. Okay. And that immediately raises flags about, can we even resect this cleanly? Is neoadjuvant therapy going to be absolutely essential to shrink it first?
Makes sense.
And importantly, we also assess the patient's sphincter tone. How strong is that muscle? If it's weak or involved by tumor, that has huge implications for quality of life after treatment, even if we cure the cancer.
Right.
It also talks about maybe options like TNT, total neoadjuvant therapy, or even watch and wait, trying to save that sphincter.
So the DRE gives us a really good initial feel for the local extent. Flags potential surgical hurdles right away.
Right.
Okay. Beyond the physical exam, what labs and imaging are essential?
Yeah.
Systemic picture confirming the diagnosis.
Okay, labs. We'll definitely get a complete blood count, a CBC. Check for anemia.
Yeah.
Pretty common with that chronic bleeding.
Right, losing blood.
Yeah, and that might affect timing of surgery, need for transfusions. We also get a comprehensive metabolic panel, a CMP. Check kidney, liver function. That's crucial before thinking about chemo, right? Doses often need adjusting. Plus, liver mets are common.
Good point. And the tumor marker, CEA.
Yep, carcinoembryonic antigen, CEA. Get a baseline level.
Nice.
Now, here's a key clinical pearl.
Okay.
CEA is not diagnostic on its own. You can have a high CEA for lots of reasons, or have rectal cancer with a normal CEA. Never use it for screening.
Got it. Not for screening.
But once you've confirmed the diagnosis, it's super valuable for tracking response to treatment and looking for recurrence later. If that CEA starts creeping up after treatment, that can be the first sign of trouble, sometimes even before you see anything on scans. It triggers an earlier look.
That's a really useful clarification on its role. Okay, imaging for diagnosis. Beyond, say, a CT for distant spread, what's the absolute must-do for the bowel itself?
A full colonoscopy. Absolutely mandatory.
Not just a sigmoidoscopy.
Nope. Full colonoscopy. And it's not just about confirming the rectal cancer, getting biopsies for pathology. It's vital for two other reasons.
Okay, what are they?
First, you precisely map the tumor's location and get tissue. Second, you have to rule out synchronous cancers elsewhere in the colon.
Synchronous meaning another separate cancer at the same time.
Exactly. Happens in maybe 3 to 5% of patients. You don't want to miss that.
Yeah.
It would totally change the surgical plan. So the colonoscopy gives you the full picture, the whole large bowel.
Okay, so we've got the biopsy confirmation, initial labs, full colonoscopy. Now, local staging is king, right? This is where the high-tech imaging comes in, guiding our treatment, especially for us, defining radiation targets. But before we jump into the MRI, let's really nail the anatomy. Understanding the local geography, you said it's non-negotiable.
Absolutely. Before we talk about fancy imaging, understanding the rectum's unique anatomy, its neighborhood, that's the bedrock. These relationships, they dictate how the tumor invades locally and, crucially for us, the routes of lymphatic spread. That defines our radiation fields. Without that anatomy knowledge, reading scans or planning treatment is, well, it's just guesswork.
Yeah.
And we can't guess.
Okay, so break down the rectal anatomy for us. How does this relationship with the peritoneum matter? How does that affect spread?
Great question. So the rectum's anatomy is really defined by how it relates to the peritoneum, that lining of the abdominal cavity. And this creates different sections with different risks. Picture the rectum. It's this tube, maybe 12, 15 centimeters long, kind of fixed, running from the sigmoid colon down to the anal canal. But it's not uniformly covered or contained. That's the key.
Not uniformly contained, meaning parts are more exposed.
Exactly. Let's start high up. The upper third, roughly the top 5 centimeters. This part's pretty mobile, and it's draped in peritoneum on the front and sides, kind of like the sigmoid colon. So a tumor here, if it punches through the wall, it could spread directly into the peritoneal cavity.
Yeah.
You could get peritoneal carcinomatosis, that diffuse spread, tough to treat.
Right. And middle third.
Moving down the middle third, maybe 5, 10 centimeters up, that's different. It only has peritoneum on its front surface, the anterior side.
Ah, okay.
So if it invades anteriorly, yes, it can hit the peritoneum. But if it grows sideways or backwards, posteriorly, it's going into the extraperitoneal space.
Yeah.
Specifically into that fatty tissue around the rectum, the mesorectum, which we'll talk a lot more about.
And then the lower third. The last 5 centimeters or so, you said this is often the critical part for local invasion, where it gets tricky.
Yeah, you got it. The lower third is absolutely key for local invasion because it's entirely extraperitoneal.
Meaning no peritoneal covering at all.
None. No serosal barrier, no peritoneal lining to help contain the spread.
And what does that mean clinically?
I mean, tumors here tend to spread directly out into the surrounding fatty mesorectum more easily, or even invade adjacent structures like the vagina, prostate, the sacrum bone. There's just less holding it back. That's a major reason why local control is such a challenge in these low rectal cancers, and why radiation often plays such a vital role down there. The local anatomy really drives the tumor's behavior.
That lack of a serosal barrier, that's a really crucial point. Okay, let's switch to lymphatic drainage. Super important for our radiation fields, right? Covering where microscopic disease might hide, even if nodes don't look big on scans. This trips people up.
Oh yeah, definitely. The lymphatic drainage, it seems complex, but thankfully is pretty predictable. Mastering it is essential for drawing those target volumes correctly.
Okay.
So for tumors in the superior half of the rectum, let's say generally above 10 centimeters in the anal verge, the main drainage route is up, cephalad.
Up towards the head.
Right. It follows the superior rectal artery, which comes off the inferior mesenteric artery, the IMA, and it drains to the inferior mesenteric artery nodes, the IMA nodes.
Okay, IMA nodes for the upper half.
Yep. They're usually up near where the aorta splits. So when you're treating these upper rectal cancers, your radiation field has to go high enough to cover that IMA basin.
Got it. And the lower half, below 10 centimeters, how's it different?
The inferior half has a different pattern, broader. It drains laterally out to the pelvic side wall.
Sideways.
Exactly. So this involves nodes like the internal iliac nodes running along the internal iliac vessels and the obturator nodes down the obturator foramen. These are the main nodes we need to cover in our standard pelvic radiation fields for those mid and lower rectal cancers. It's why our field covers those lateral pelvic areas.
Okay, so upper goes up, IMA, lower goes out, pelvic sidewall. Clear distinction. Now, I remember there's a really important clinical pearl here, something that comes up on boards a lot and matters for treating really low tumors.
Ah, yes. You're hitting on a key point. Definitely a board favorite because it's an exception and it matters clinically.
Okay, lay it on us.
Here's the deal, and a way to remember it. If a low rectal tumor invades down into the anal canal, specifically below the dentate line.
A dentate line, that's the transition zone in the anal canal.
Exactly. Where the rectal mucosa changes to the special anoderm skin. Think kind of where internal and external hemorrhoids meet. If the tumor crosses that line downwards, its lymphatic drainage pattern changes dramatically. It doesn't just go up or laterally anymore. It can also drain down to the superficial inguinal nodes, the groin nodes.
Wow, okay, so that's a totally different pathway, usually just for anal canal cancers, right?
Yeah.
But applies here if the rectal tumor grows down that far. You mentioned a mnemonic.
Yep. To help burn this into your memory for field design, think deep down dirty drainage.
Deep down, dirty drainage. Okay,
Nice.
break that down.
Deep down reminds you it's a tumor that's invaded low, below the dentate line, into the anal canal, and dirty drainage tells you it can drain to those superficial inguinal nodes, which is, not the usual clean pathway for rectal cancer. It's an important, less common route to cover.
So you wouldn't normally treat the groin nodes for a mid-rectal cancer.
Correct.
But if it's a really low tumor and it's clearly invading the anal canal, you have to include the inguinal nodes in your radiation field.
You got it. Small anatomical detail, big practical impact on treatment planning. Don't miss that high-risk basin.
That's a great mnemonic, deep down, dirty drainage. Really sticks. Okay, so cancer confirmed, anatomy reviewed, local staging is paramount, endoscopic ultrasound, EUS, used to be common, right? But what's the modern gold standard now for getting the most critical info for almost everyone?
Yeah, EUS had its day, especially for early T-stage assessment. But the modern standard, really the cornerstone now for local staging, is a high-quality pelvic protocol magnetic resonance imaging, MRI.
Not just any MRI, though.
No, definitely not. It needs to be specifically tailored. Thin slices, high-resolution sequences like T2 imaging, often using a special coil, a phased array coil, to get really sharp pictures of the rectum, the mesorectum around it, and that critical mesorectal fascia. It's just way better than EUS for seeing the whole mesorectum, and it gives us two absolutely essential pieces of info that really drive how we manage rectal cancer.
Okay, what are those two critical pieces of information from this specialized MRI?
First, the MRI is excellent, really sensitive and specific for figuring out the depth of invasion, the T stage, and spotting suspicious pelvic lymph nodes, the N stage.
Better than CT for that.
Oh, much better for local detail. It can clearly tell a T2 tumor confined to the muscle wall from a T3, which is broken through into the mesorectal fat. It can even pick up subtle signs of T4 invasion into nearby structures. That detail guides our understanding, tells us if neoadjuvant therapy is likely needed.
And for nodes.
Again, way better than CT for pelvic nodes. CT is good for distant mets, but MRI lets us look at the node's characteristics, size, sure, but also shape, signal, internal texture, things that suggest malignancy much better than just size alone.
Okay, so precise T and N staging. What's the second, arguably even more important piece of info the MRI gives us? You mentioned something about the margin, CRM.
Yes, you nailed it. The circumferential resection margin, or CRM. This is arguably the single most important prediction we get from the pre-op MRI, especially for deciding on neoadjuvant treatment.
Okay, tell us about the CRM. What is it exactly?
To get it, we need that anatomy again. Remember, the rectum sits inside this fatty envelope, the mesorectum, and that whole package is wrapped in a thin but tough sheath called the mesorectal fascia.
Right, the ideal surgical plane.
Exactly. That fascia is the natural boundary surgeons aim for during TME surgery to get the tumor out cleanly. The CRM is simply the shortest distance, measured right on the MRI scan in millimeters from the outermost edge of the tumor or any suspicious node nearby to that mesorectal fascia.
So it's predicting how close the tumor is to that ideal cut edge.
Precisely. It's predicting the likelihood of leaving microscopic disease behind if the patient goes straight to surgery.
Okay, so what are the critical cutoff numbers we need to know for the CRM, and why is it so significant?
This is absolutely crucial. Board exams, clinic, everywhere. A CRM of less than 1 millimeter. That's considered involved or positive.
Less than 1 millimeter is involved.
Right. It means if the surgeon cuts along that fascia, there's an extremely high chance microscopic tumor cells get left behind. Positive margin. Bad news.
Okay. And what about slightly further away?
A CRM between 1 and 2 millimeters. That's considered threatened.
Threatened, okay.
It's not overtly touching, but it's close enough that there's still a very high risk of microscopic disease being left after surgery. These aren't random numbers. They come from years of linking pathology results back to outcomes.
And the clinical significance. Why care so much before surgery? Why not just wait for the path report after?
Because the clinical significance is massive. This is a cornerstone of modern rectal cancer care. A threatened or involved CRM on that pre-op MRI is a major predictor of local recurrence after surgery. Independent predictor.
Meaning the cancer coming back in the pelvis.
Exactly. If we go straight to surgery with that predicted positive or threatened margin, the chance of pelvic recurrence is significantly higher. So seeing that on the MRI, that's a primary reason, a very strong indication to recommend neoadjuvant therapy.
Treatment before surgery.
Right. Usually radiation, often with chemo. The goal is to shrink the tumor, kill off those microscopic cells at the edge, and turn that threatened or involved margin into a clear one by the time surgery happens. Maximize local control, prevent recurrence. This one measurement guides a huge clinical decision.
Understanding the anatomy, the fascia, the CRM on MRI, it leads perfectly into talking about TME, right? Total Mesorectal Excision. You said it was a huge surgical innovation.
Oh, absolutely revolutionary. It created a clear before and after in rectal cancer outcomes.
What was it like before?
Before TME, so before the early 90s mainly, surgery was often blunt dissection. Surgeons used fingers, blunt tools to sort of push the rectum away from surrounding tissues. No clear view of the planes.
And the problem with that?
The huge problem was it frequently tore or went right through that delicate mesorectal fascia, that critical sheath around the mesorectum.
Leaving disease behind.
Exactly. Leaving microscopic disease scattered in the pelvis. An incomplete resection, even if they thought they got it all. And the result? Local recurrence rates were alarmingly high, often 30 to 40%.
Wow, almost half the patients.
Yeah, imagine. Nearly half had the cancer come back right there in the pelvis after what was considered successful surgery. That was the reality.
So TME, how did it change things so dramatically? What was the big idea?
TME, pioneered by the brilliant British surgeon Bill Heald, was a total paradigm shift. Instead of blunt pushing, it's precise, sharp dissection, using scissors, cautery, under direct vision.
Okay.
The goal is to meticulously remove the entire rectum along with its intact mesorectal envelope, the whole package.
Like unwrapping a gift carefully.
That's a perfect analogy. You keep the wrapping paper, the mesorectal fascia, totally intact. No tears, no holes. It's an en-bloc resection. The tumor and all its local drainage, the fat, the nodes within the mesorectum come out as one complete contained unit. The surgeon stays outside that fascial plane the whole time.
Resulting in cleaner margins.
Much higher rate of RL0 complete resections, yes.
So this meticulous technique, what was the actual impact? Those recurrence rates must have plummeted.
Oh, the impact was revolutionary. And crucially, it wasn't just doing a TME that mattered. It was the quality of the TME. How intact was that specimen when the pathologist looked at it?
The quality mattered.
Immensely. And this was proven by the landmark MRC CR07 trial, published in the early 2000s. Huge trial. It provided definitive proof. They meticulously graded the surgical specimen quality based on the integrity of that mesorectal plane after surgery.
How did they grade it, and what were the outcomes? This is the key part.
Right. The results were just striking, crystal clear. They basically found 3 main grades of surgical plane based on the pathology.
Okay.
First, a clean, intact mesorectal plane. This is the ideal surgeon. Stayed outside the fascia, removed it all intact. The 3-year local recurrence rate for these patients, just 4%.
4%, down from 30–40%.
Incredible, right? Then second, an irregular dissection into the intramesorectal plane, meaning the surgeon got inside the fascia, into the fatty envelope itself, but mostly stayed within it. Recurrence rate here, 7%.
Still good, but not as good.
Exactly. showed the importance of staying outside that fascia. And third, a poor dissection that violated the muscularis propria plane. This meant the cut went too deep, right into the muscle wall of the rectum itself. Very poor quality. Recurrence rate, 13%.
Wow. So 4% versus 13% just based on how well the surgery was done, how clean that plane was. That's profound. What did this mean overall?
It meant TME set a completely new, incredibly high benchmark for surgical quality in rectal cancer. It slashed local recurrence rates down to single digits when done well.
Right.
And this dramatic improvement from surgery alone, it then set the stage for the next big questions in multidisciplinary care. Okay, surgery's great now, but can we do even better? Can adding radiation or chemo improve on these already excellent surgical results?
It shifted the focus.
Totally. Local recurrence went from being mainly a surgical failure problem to something surgery could handle incredibly well. That let us ask, how can other treatments like radiation build on that success? That's the foundation for all our modern integrated strategies.
It's amazing how one surgical technique could reshape everything. Okay, so building on all of that, the presentation, the anatomy, the MRI findings like CRM, the impact of TME quality, how does this all tie together in the clinic day to day? What's the key decision point for us?
Yeah, this brings it all together. And it's something every resident needs to nail.
Yeah.
When we see that threatened or involved CRM on the pre-op MRI, remember 1 millimeter or less than 1 millimeter?
Right.
That's not just a finding to note down. It's a strong, actionable signal. It tells us the patient will likely benefit significantly from neoadjuvant therapy.
So treatment before surgery.
Exactly. We recommend radiation, usually with chemotherapy, given before any surgery happens.
And the goals of that neoadjuvant treatment in this specific situation?
It's multi-pronged. First, maximize local control, kill any microscopic disease hanging out near that predicted tight margin. Second, downstage the tumor, shrink it, maybe make it T4 to T3, clear some nodes.
Okay.
Third, especially for those low tumors, maybe shrink it enough to allow for sphincter preservation. Avoid the permanent colostomy. We want to convert that threatened or involved margin into a clear one, or at least drastically reduce the risk of a positive margin at surgery. That upfront treatment just dramatically ups the chance of a clean Aradero resection.
And this is where that multidisciplinary care really shines, isn't it? TME was foundational, the surgical piece, but the MRI predicting that risky CRM beforehand lets the whole team surgeon, medical oncologist, us as radiation oncologists, use radiation and chemo up front. It's about combining forces, right? Using radiation chemo to potentially clear a margin that surgery alone might miss, or just reduce the recurrence risk even more. Optimizing the chance of cure, maybe saving the sphincter. It's a total team effort.
It really underscores that no single treatment is the whole answer. It's the smart sequence, the right combination, all guided by accurate staging that gets the best results, is how far we've come.
Couldn't agree more. Okay, let's solidify this with our board blitz section. Ready for some quick-fire questions based on what we've covered?
Let's do it. Great way to lock in these concepts.
Okay, case 1. Pelvic MRI for rectal cancer staging shows a tumor going through the muscularis propria. The closest margin to the mesorectal fascia measures 1.5 millimeters. How would you characterize this CRM A clear, B threatened, C involved, or D indeterminate?
Okay, 1.5 millimeters. That falls squarely into category B, threatened.
Explain why.
Because, as we said, the distance to the fascia is key. Less than 1 millimeter is an C. 1 to 2 millimeters, which includes 1.5 millimeter, is defined as threatened. It signals that high risk for a positive margin if they go straight to surgery, making it a strong reason for neoadjuvant therapy. Clear A would be over 2 millimeters. Indeterminate, D doesn't apply here, so B threatened.
Excellent breakdown. Case 2. Patient has a rectal adenocarcinoma. It's located high up in the superior half of the rectum, 12 centimeters from the anal verge. Which primary nodal basin would this tumor most likely drain to? A, internal iliac nodes, B, superficial inguinal nodes, C, inferior mesenteric artery, IMA nodes, or D, external iliac nodes.
Okay, superior half, 12 centimeters above. That drains primarily cephalad, upwards. So the answer is C, the inferior mesenteric artery nodes.
And we're not the others.
Well, A and D, the iliac nodes, that's the lateral pelvic drainage pattern, typical for lower or mid-rectal tumors. And B, the superficial inguinals, that's our deep down dirty drainage scenario, only if it invades the low anal canal. So for a high rectal tumor like this, it's C, IMA nodes.
Perfect logic. Final one, case 3. The surgical technique of total mesorectal excision, TME, involves the unblock removal of the rectum and which surrounding structure. A, the entire pelvic floor musculature, B, the internal and external iliac lymph node chains. C, the mesorectum, including its enveloping fascia. Or D, a segment of the sigmoid colon and bladder.
The core of TME is C, removing the rectum along with the mesorectum, including its enveloping fascia. That's the whole point, getting that intact, fatty, lymphatic-bearing envelope out with the tumor.
Why not the others again?
A, the pelvic floor muscles isn't the target unless invaded. B, the iliac nodes are treated by radiation if needed, but not typically removed en bloc with the TME specimen itself.
Yeah.
And D, sigmoid and bladder only if directly invaded. TME is about the rectum and its immediate mesorectal package, defined by that fascia. So, C.
Fantastic. Nailed the board blitz. It really shows how critical these fundamentals are. So we've seen how TME was this huge leap, slashing local recurrence from, 30-40% down to maybe 4-13%, depending on surgical quality.
Monumental. Absolutely monumental. And that success, that massive drop in local recurrence, just from better surgery, it immediately created a new challenge, didn't it? And a whole new field of research.
Which was?
How do we improve on these already excellent results? If surgery is doing so well, when do we actually need to add radiation and chemo?
Yeah.
And how should we add them? Can we push those numbers even lower? Or maybe can we get the same great results, but with less toxicity by being smarter about who gets what?
Yeah.
That became the next big frontier, spawned tons of trials.
And this is where things get really dynamic today, right? What are some of the key ongoing debates or advances residents should know about building on this TME foundation?
Oh yeah, huge area of flux. One major trend is towards total neoadjuvant therapy, TNT.
TNT.
Traditionally, it might have been neoadjuvant chemoradiation, then surgery, then maybe adjuvant chemo after. TNT flips that tries to get all the systemic chemo and radiation done before surgery.
And why do that? What are the big trials?
Landmark trials like Rapido and Prodigy 23 tested this. They compared standard sequencing to a TNT approach. The idea is maybe hitting micrometastases earlier with full chemo and potentially getting better tumor shrinkage before surgery.
And the results. What's the takeaway from TNT trials?
Well, Rapido, for example, showed TNT improved disease-free survival and cut down distant recurrence, although local control was excellent in both groups thanks to TME.
So better systemic control.
Seems like it. The controversy is often around toxicity. Are we giving more treatment up front? Is it worth it? But for many patients, especially those with high-risk features, T3, T4, node positive, that threatened CRM we talked about, the answer seems to be leaning towards yes. TNT is really gaining traction for intermediate and high-risk folks.
Makes sense. Intensifying up front for some. What about the flip side? Can we do less treatment for certain patients? De-escalation.
Absolutely. That's the other really exciting area, especially the idea of organ preservation, or watch and wait.
Avoiding surgery altogether.
Potentially, yes. For patients who have a clinical complete response after neoadjuvant chemoradiation, meaning the tumor seems to completely disappear on exam, scope, and MRI.
Wow.
Trials like the OPRA trial from MSKCC have explored just watching these patients closely instead of proceeding to surgery.
That seems amazing, but maybe a bit scary. What are the pros and cons?
The pro is huge. Avoid major surgery, keep the rectum, no stoma, great quality of life. The con, or the risk, is local regrowth. The tumor comes back locally in maybe 10-25% of patients managed this way.
So the controversy is?
It's about selecting the right patients very carefully, the need for intense surveillance, managing patient anxiety. It's not for everyone, but it highlights this massive shift towards truly individualized, risk-adapted therapy. Who needs more? Who can safely get less? It's not one size fits all anymore. We're balancing cure with quality of life in ways we couldn't before. That's the cutting edge now.
It really shows how dynamic and patient-focused rectal cancer care has become. Amazing. Okay, let's recap the absolute key takeaways from today's foundational discussion, part 1.
Sounds good. First, that high-quality pelvic MRI. Absolutely essential. For accurate local staging TNN, and critically, for assessing the circumferential resection margin, the CRM. That MRI drives the initial decision about needing neoadjuvant therapy.
Right. Second, the mesorectal fascia. It's not just anatomy trivia, it's the crucial surgical landmark. Keeping it intact during surgery is paramount for preventing local recurrence. The MRC CR07 trial proved that link between surgical quality and outcome.
And finally, total mesorectal excision, TME. It truly revolutionized rectal cancer surgery. It slashed local recurrence rates down under 10% when done with a clean mesorectal plane. Set the global standard for surgical quality, totally changed the outlook for patients.
These are absolutely the building blocks. Understanding these lets us ask the next crucial questions, the ones driving research and practice today. Given how good TME is, how do we best combine radiation with it? Who actually needs the radiation? And how do we tailor that intensify or de-escalate based on the specific patient and their tumor?
And you can dive deeper with practice oral boards and more reviews over at radongsmartlearn.com. That's radongsmartlearn.com. And definitely subscribe to Radong Smart Review for our next session.
Because in our next session, Rectal Cancer Part 2, we'll build right on this foundation. We'll tackle those exact questions. When do we add radiation to TME? How do we deliver short course versus long course chemoradiation? Who benefits most?
Thanks for joining us for this deep dive into rectal cancer fundamentals. As you go forward, always think not just what treatment, but why, and how it impacts the whole patient journey, balancing cure and quality of life. That's the real goal now, isn't it? Helping people thrive beyond their diagnosis.